Yay! It's okay, I won't take it personal. All right, so the last sort of disorder that I want to talk about before we move on to sort of infections and burns is the vesiculobulbous disorders. And the highlight or the example that I really want to try to focus on this morning is a disorder called erythema multiforme. And hold on, I always get busy and I forget whether or not I turned on the recording. Why is it not recording? Yes, good. Okay, just wanted to make sure for you guys. All right. Erythema multiforme. So this is a kind of a strange disorder that I honestly had never heard of and really had no experience with at all until I became a new grad and was working in the ER. Anyone heard of this or know anything about it? There's a couple different forms of it, and we'll talk about it. But pathophysiologically speaking, it's an acute, recurring disorder of the skin and the mucous membrane. So it's not just the skin that's involved. It can actually be the mucous membrane. So the inside of the mouth, the inside of the respiratory tract, the conjunctiva in your eyes. Really, any mucous membrane layer can be affected by this. And it's associated with either an allergic or some sort of toxic reaction to usually a medication. And when I say drugs on here, I don't mean like street drugs. I mean like medication, usually antibiotics, actually. And what happens is that it's caused by this immune complexes that are formed and deposited around dermal blood vessels, basement membranes, and keratinocytes. I have trouble saying that word too. Either in the skin or, again, in the mucous membranes. And what you will see sort of actually happening here is basically like these little sort of ulcerations or these little lesions that kind of create this sort of bullseye effect. So you have these sort of red regions that's sort of in a ring area that sort of are swollen and edematous and sort of inflamed. And as they kind of spread and grow out, it really does form sort of this bullseye look to it, where it's kind of got these red rings with these lighter sort of inner circles in the inside. So bullous lesions then form erosion, so it kind of forms like this little erosion of the skin that then kind of crusts over when those erosions kind of break open and rupture. So these lesions aren't necessarily fluid-filled the way those other sort of vesicles were that we talked about, but they do kind of break open because the skin gets so thin in that area that they just kind of erupt and sort of break open. And then the edges of that get crusty, and you see this very sort of crusty look to these lesions after they sort of break open. So the areas that are most affected are the mouth, as I said, respiratory tract, so air passages, esophagus. It can also get so bad that it affects like the urinary tract, so the inner lining of the urethra and things like that, and the conjunctiva, so the the mucous membranes on the inside of your eyelids and things like that. So depending on what part of the body is affected, or to the degree that these mucous membranes and skin is affected, is totally individual. It's a very individual response, and again, it unfortunately happens to someone who honestly just kind of has bad luck, unfortunately, and they kind of have this allergic reaction to, usually, like I said, a medication. So you can't necessarily predict which meds do it. It's just that particular individual has that particular bad response, essentially, to that particular medication. Here's actually a really great picture of a specific form of multiforme, erythema multiforme, and that is Stevens-Johnson syndrome. I actually had I had no experience with this. I had never heard of this. And working as a new grad in the ER, one of my very first ER jobs, I had a young girl, teenage girl, come in for this. She had been something very run-of-the-mill, like she had an upper respiratory tract infection, and then started an antibiotic, and then several days later, she literally shows up to the ER. Her body was covered in these types of sort of lesions like this. And you can see what I mean, how the skin just kind of erodes. See this sort of underneath layers of skin that are exposed with this red sort of ring around it. All of these will eventually break open. And so this is someone's back. So you can imagine when all of these break open what this looks like, right? And again, if this happens on the eyes, it can cause corneal abrasions and blindness. It can, obviously, if it's in the respiratory tract, it causes difficulties with breathing. If it's in the GI tract, eating, obviously. Urinating, obviously, if it's in the, the urinary tract. So they can have severe, severe manifestations. We're talking like needing to go to the ICU on an intubate, or, on a ventilator, intubated kind of thing. If this is what the sort of inner passages of the respiratory tract look like. Again, this is someone's back. Profound skin peeling, loss of skin. I mean, just the whole skin can just sort of slough off. And again, this was the teenager that I took care of. Young girl, totally normal, healthy, active, had just an awful reaction to the specific antibiotic that she was put on for her upper respiratory tract infection. Treatment in its mild forms is pretty self-limiting. So again, I would not say this is a mild form, but can be pretty self-limiting. So in 10 to 14 days, the crusts kind of dry out, the skin starts to heal again with sort of minimal scarring. This person, though, again, if this is what their skin looks like, who knows what their mucous membranes look like, their respiratory tract looks like. I have seen people come into the ER needing, like I said, to be intubated and ventilated for a while because of how their respiratory tract has been impacted. Other ways to obviously address this is topical and oral steroids, actually to the skin. Obviously, this is very painful, so some topical anesthetics or maybe even more systemic pain medications. And fluid and electrolytes would also be really important in someone with a severe case of Stevens-Johnson. Why would that be? Why would fluid and electrolyte balance and keeping a close eye on that be so important? What do you think? Mm-hmm. Yeah. Yeah. So anytime your skin is open like this, you're obviously losing sort of insensible loss of fluids, right? Your skin is a good barrier to keep some of that fluid in our system. So if your skin is open to the environment, you're losing a lot of insensible loss just of fluid out in contact with the environment. So major fluid and electrolyte concern, because you're basically losing, especially when it's this bad, you're losing that first barrier, right? So not only are you at risk for loss of fluid and loss of sort of electrolytes through that fluid, you're also at a huge risk for what? Infection. Right. Very good. So, and more mild versions, it can be literally like, oh, take some, topical steroids. In more systemic versions like this, it's sometimes an ICU admission, fluid and electrolyte watching, infection, antibiotics, things like that. Again, this is a form of a vesiculobullous disorders, and again, kind of an example of erythema multiforme. This one specifically is called Stevens-Johnson. All right. We're going to quickly talk about specific types of infections. We're not going to spend a lot of time with this because some of this is kind of redundant of things we've already talked about throughout the semester. Bacterial infections, those would be some of those things we've already talked about when we talked about like bacterial infections. I had that, remember on bacterial infection slide, I had that lovely link to that YouTube video of someone getting their boil IND'd. That would be a bacterial infection, right? And that's because of something called folliculitis. So folliculitis is a bacterial infection of the hair follicle, which is probably how that guy's in that video got started. Just an infection of the hair follicle that then can turn into sort of a bigger problem. So if a follicle gets inflamed or infected, it can turn into something called a furuncle, which is more of sort of the clinical term for a boil. So a boil or a furuncle is inflammation of multiple hair follicles, usually on the back of the neck, in the groin, in the armpit. Those are some of the areas that you see it most commonly sort of occurring. And what happens is that you'll get this sort of initial lesion. It's very deep, firm, sort of, feeling to the skin if you would touch that area, very red. The reason that it's so deep and red and firm is because there's so much pressure from that exudate in those follicles sort of building up and building up and building up. So it's also extremely painful because it's really a high pressure kind of situation in those follicles that are obviously not meant to be holding so much fluid and exudate in them. So that's kind of the patho of a boil or of a furuncle. Within a few days, it can kind of get like a cystic nodule where it kind of gets walled off and encapsulated into sort of like this cyst under the skin full of that exudate. And what happens is either it will break open on itself because of the high pressure, or you have to go get an IND, which stands for incision and drainage, which is that video on that YouTube example I showed you, where they actually have to kind of use a scalpel and sort of cut it open and get all that excess exudate out. Now again, that can actually get worse than two and become what they call a carbuncle, which is like a bunch of boils or a bunch of furuncles together. So that's an even sort of larger area of infection. So a collection of infected hair follicles would be a carbuncle. And not only will you see that cyst that's sort of full of the exudate in that localized area, what you can also start to see around that area is cellulitis. And what I mean by cellulitis is infection of the skin around it. So infection of the dermis and the subcutaneous tissue. And again, usually these things like boils and then carbuncles are caused by bacteria, specifically usually staph. And again, why, if you see that type of manifestation, that, you know, big boil with a lot of exudate, with a lot of that, again, what we would call non-clinically pus, why do we sort of assume then automatically that it's a bacterial infection? Remember I told you in our sort of infection talk? Because of the white blood cell activity in that area. Right, very good. So usually if you see pus or exudate in some type of infected area, it's usually a bacterial infection because of the way that a bacteria engages the white blood cells. And that's sort of those dead white blood cells is what causes that exudate and that pus in that area. Good. Very good. So if you didn't already see my lovely video that I linked to our lecture a while back, please enjoy. Here's another smaller picture of that. So you see kind of here this kind of, you can kind of see the head of this furuncle here. But what you don't see is sort of the underground aspect of how deep this goes and how much exudate is sort of underneath those layers of the dermis and underneath those layers of the skin, which is what causes so much pain because of that increased pressure in those tight little spaces. But either furuncle or carbuncle usually need to be IND to drain it and get that infection out. Oftentimes, depending on how bad it is, and I've seen this in the ER a lot when we do INDs, these people will be put on an antibiotic. And if it's so bad, they might actually start them on a dose of IV antibiotics just to make sure the infection doesn't spread. And again, you also may see redness around that area, which is cellulitis. So inflammation or infection of the skin and the dermis and the subcutaneous layers around that actual, epicenter of the infection. All right. Lovely talk this morning. The other sort of category of infections are viral infections. I'm actually not going to spend a lot of time on this today, but just kind of give you an example. The big sort of viral infections that we'll see the most, clinically speaking, have to do sort of with the herpes family, either chickenpox or herpes simplex virus, like your cold sore kind of thing, or herpes zoster, shingles, which we know is sort of that sort of dormant version of chickenpox that lays dormant on nerve fibers that then kind of come up to the skin surface and create these vesicles, these blisters that are filled with fluid. Again, in the same family as chickenpox, but it's a different monster, so to speak. We're not going to spend a lot of time on viral infections today. I have a slide here for you. I also have a couple of pictures of, this says herpes simplex virus. This is actually just the herpes simplex virus. This is a good example of shingles, and you can see, or herpes zoster. This is a good example of it because you can see how it just lays on one dermatome. It's in sort of one straight line because it's all sort of been laying dormant on one nerve dermatome that sort of feeds this area right here. But you're not going to need to know much about herpes. Okay, and here's an example of the dermatomes that can get affected in shingles, but kind of an FYI for you. Okay, the last infection I want to talk about here before we move into burns is fungal infections, and we'll kind of briefly talk about this too. Fungi usually causes superficial skin lesions, and these are usually called your dermatophytes. We talked about how in our infection lecture a couple of weeks back that you can have sort of superficial skin disturbances because of fungal infections, but also your deeper sort of systemic or organ fungal infections, but those are usually more reserved for people who have some sort of depressed immune system or something like that. And here's a kind of a list of different types of fungal infections that you might see. So athlete's foot is tinea pedis, on your scalp is tinea capitis. But really and you can kind of see other areas that can become infected with fungal infections as well. But what you see with fungal infections are sort of this superficial kind of skin disorders, usually found, as I mentioned previously in our previous lecture, in areas of moist, sort of wet, warm environments. So treatment is usually related to whatever type of fungus is present and includes either topical or systemic antifungal medications depending on how bad it is. But most of the time these things, especially like athlete's foot, area, in the groin and things like that, have to do with literally it just being a warm, moist environment. So here's a good picture of tinea pedis, or athlete's foot, fungal infection of the foot. And what you see, sort of how it's sort of characterized and how it's manifested, is usually this very sort of thin, flaky skin that just sort of flakes off in sort of this plaquey sort of distribution. This is a great picture of athlete's foot. And so oftentimes, you don't even necessarily need an antifungal. You literally just need to sort of dry out the environment, dry out the system. I had a patient, a frequent flyer kind of guy in the ER in New York that would always come in with this foot pain. He'd always come in complaining of this burning pain in his feet. He was a homeless gentleman who, unfortunately, especially in the middle of the winter or the cold months in New York, he would literally have the same pairs of sock on for, months, weeks. They would get wet, and then they would dry out again, and they'd get wet, and then they could dry out. He just has these wet socks on for weeks, the same ones. So we'd literally, take his shoes off, take his socks off. Lo and behold, yep, this is what his feet would look like. And so we would talk to him about, I worked nights in New York, and we would literally say, okay, when the sun comes up, go to Central Park, take your boots off, take your socks off, and just sit there and let things dry out, because that's really the only reason why this is happening, is because you just have this warm, moist environment constantly going on. You're just living in these wet socks. And so, honestly, that was going to be the best fix for this guy, was to literally just get those wet socks off and don't have the same socks on for weeks at a time without ever removing them. This is also referred to sort of as trench foot from World War I, where the guys would literally eat, sleep, drink, repeat, kind of thing for days and days, weeks and weeks at a time in those trenches, had the same wet socks on, the same wet boots on for weeks at a time. They'd get this, and really the only fix, really the only thing that they really needed to do was dry out that environment. Just take those wet socks off, take those wet boots off, and let it dry out, because that's the environment that the fungus likes, right? So I'd always tell this patient that. Now, did he ever do it? I don't know. I never saw him sitting in Central Park with his shoes off, but I hope he did, because that really would be the fix. Coming in at 3 a.m. to the ER for this, you really don't have to come in at 3 a.m. to the emergency room. You could literally just go outside and take your socks off. But anyway, just kind of an example of that, of fungal infections. Again, superficial. Okay. Burns. Again, a lot of this might be information that you've heard about. We kind of talk about, oh, that was a first-degree burn, that was a second-degree burn, whatever. But let's make sense of it. Let's actually talk about what you see pathophysiologically with, skin disturbances after a burn injury. So, and again, unfortunately, working in the ER and having a ER and trauma background, pretty familiar with this content, unfortunately. So let's go through these. So a first-degree burn, okay, so not only am I going to tell you sort of the name of the type of burn, but what structures are impacted, and then kind of what the manifestations you might see are. So first-degree burn, destruction only of the epidermis, so of the outermost layer of skin. Skin maintains all of its properties, so it still maintains its water vapor and bacterial sort of barrier functions. So what you'll see is sort of just local pain, local redness, erythema, and you usually don't see blisters with a first-degree burn. So given that definition, what's an example of a first-degree burn? Sunburn. Perfect. So if you want to picture a first-degree burn, think of a pretty mild sunburn. Okay. Then you have your next step, which is second-degree burns. Now, there's kind of two forms of second-degree burns. There is what you see here on the screen, superficial burn, and then on the next slide we have deep partial thickness burn, and that's also considered a second-degree burn. So there's two types of second-degree burns. Here's the first one, superficial burn. So with this type of second degree burn, you see destruction of the epidermis like you did in the first degree burn, and now some of the actual dermis, so that second bigger layer of skin. What you will see here are thin-walled, sort of fluid-filled blisters that develop within just a few minutes after the burn occurs. The good thing about second-degree sort of superficial burns is that sensory remains intact. I say good thing, but that's what makes the burn hurt so bad, right? Because your sensory fibers, your nerves are still intact. But again, given this definition of the manifestations, thin-walled, fluid-filled blisters, give me an example of a superficial second-degree burn. Yeah, burn your finger on the curling iron, burn your wrist on the metal rack in the oven as you're pulling out your food, those kinds of things. Where you have that sort of local little area with the blisters that form like pretty quickly right after the actual injury has occurred. Good. Very good. So burn yourself on the oven rack. You could also actually include this in like a bad sunburn that blisters. This is a second degree burn, a superficial second degree burn. Both of these kind of burns, though, the patient's skin is still pretty intact in the fact that they can still sort of thermoregulate, they can still feel it, their nerves are still intact. It's very kind of, well, with the superficial burn, it's very sort of wet. There's a lot of fluid, like that fluid that fills up in those blisters. It's very kind of a wet wound, so to speak. Okay. The next type of burn is still a second degree burn, but it's a little bit worse. In terms of the sort of degree of the skin that's impacted. So this is what we call a deep partial thickness burn. Again, still considered a second degree burn, but just a little bit worse because it involves the epidermis and the entire dermis now. It usually does spare a lot of the skin sort of appendages or supporting cast of characters, so to speak. So hair follicles are still intact, sweat glands are still intact, so the person still sweats and has sort of that thermoregulatory function is still there. But now, because there's so much epidermis and dermis that has been injured, the wound looks very waxy. It doesn't look as wet and sort of, blistery as like the other second degree burn that we talked about. It takes a lot longer to heal. And now, because you have burned through the epidermis and the entire dermis, there can be, vessels that have been damaged and impacted as well. So you'll see some sort of sometimes necrotic tissue that forms because of the death of blood vessels in that area. That necrotic tissue can be very sort of damaging to the rest of the good skin around. So that oftentimes we'll want to surgically remove that tissue so that the tissue underneath and the tissue around it can start to heal and start to get adequate blood flow to it to be able to sort of heal. Oftentimes this is now the type of burn that will now start to need a skin graft, if you've heard that term before. As you see here on the screen, autograft, where they take so it's this person's own skin from another part of their body and lay it over top to sort of take root and sort of patch up that area where the skin has been completely damaged and will not grow back. So this is the first type of burn now that we've talked about that would, again, if it covers a large area, would need a skin graft. And healing results of this particular type of burn in that very sort of classic hypertrophic scar with poor function that you think of when you think of like scarring from a burn. This is the first type of burn that will heal in that very hypertrophic way. Not only is the skin very thick and hypertrophic, meaning it kind of is a different texture and it kind of sticks up differently than the rest of the skin. With poor functioning, it has decreased elasticity, decreased collagen, and it can actually restrict movement, especially if it's in areas over a joint. So if it's like an area over the elbow or the knee, it can actually restrict joint movement because of how tough and stiff that skin is that grows back. So now we're talking about issues with mobility and things like that in that particular area of the skin. And then the last type of burn is a third degree burn. Now this is sort of the worst type of burn that can happen. It's destruction of the entire epidermis, the entire dermis, and now underlying subcutaneous tissue. Now this type of wound is again, because it's so extensive, it's pretty disturbing to see. Because the wound has a very sort of dry, leathery appearance to it. Again, when you think of wounds, when you think of burns, you think of that sort of red, weepy, kind of gooey look to burns. Because so much of the underlying tissue, blood vessels, subcutaneous tissue, etc., has been damaged, it looks very dry and leathery. There's not a lot of wetness or weepy sort of substance going on in that area. Again, because of the extreme amount of damage to an area, if you have a circumferential third-degree burn, like that goes all the way around the arm, or all the way around the leg, or even all the way around the torso kind of thing, it can cause issues distally with circulation, because it actually kind of acts like a tourniquet or like a rubber band sort of tied around that area, and does not allow for good sort of adequate arterial blood flow to areas past that area, because the tissue can get so tight and taut around that area that it basically acts as a tourniquet or like a rubber band to those distal structures. So circumferential burns can be really, really dangerous because it cuts off blood supply distal to that burn. Oftentimes we'll have to do something called an escharotomy to release that pressure. They'll actually have to cut, like as the burn heals and it starts to scar with those hypertrophic scars and gets really tight and taut, they'll actually have to cut the scar to sort of release that pressure and allow for blood flow to get distal to it. And they refer to that as an escharotomy to prevent compartment syndrome. Compartment syndrome is just a lack of, we'll talk about this next semester when we talk about musculoskeletal problems, but it's just a lack of blood flow to a particular area because of the compartment being so tight and taut that it acts as a tourniquet to the blood flow distal to that area. Also, not only is it really, again, as a clinician taking care of a patient with this type of burn, not only is it really sort of creepy to see a wound that's really dry and leathery, but also that it's painless. So I've seen third-degree burn patients come in with these extensive burns, and it doesn't hurt. They're not in pain. Again, not a good sign. It means that nerve endings have been destroyed and burned as well, and it honestly does not hurt them. So again, this is your worst, your sort of most severe type of burn, and that's a third-degree burn. Yeah. It depends on the extent. She asked you, do they get feeling back once it starts to heal? It depends on the extent of the burn and how much sort of scar tissue then forms and sort of comes back to that area. Oftentimes, these burns are so bad that the wound themselves, the scar that sort of forms and the tissue that sort of replaces it is that very sort of non-functional, hypertrophic sort of scar tissue. So oftentimes, the sensation to that area will always be altered because it's very sort of non-functional tissue that takes its place. Yeah, question? Yeah, sure. Yeah, absolutely. The mucous membranes can be burned in the same way that skin can be burned. Yeah. Mm-hmm. And when we're talking about sort of massive, widespread burns, specifically like, in the ER, we'd have someone come in, because of like a house fire, or oftentimes I feel like we always get like abandoned house fires, right? Where there's a lot of like drug activity going on in these abandoned homes, and then the house catches on fire, and you come in with these awful, awful burn injuries. We categorize the extent of how much of the body is burned by something called the rule of nines. So the extent of the total body surface area, so TBSA, how much of that is burned, is we sort of break up the body into percentages in certain areas of the body. And I have a picture of that in just a second. In fact, I'll go to that now just so we don't. So see how when you're looking at the front of the body and then the back of the body, the head is 9%, each arm is 9%, legs are 9%, torso is 9% put together, 18%. So that's how we know how bad a burn is, as we'll sort of add up and sort of calculate what percent of the body is burned, depending on which parts of the body are burned. And we'll talk about this in just a second, but oftentimes burns exceeding 40% of the body, the total body surface area, are what they consider major burn injuries, and these people are at, they're sick patients. Their mortality rate is quite low, anything over sort of 40%. We'll talk about a little bit about why that is in just a second. But let's go back and take a look at some of these pictures again here. Okay, so this is an example of a superficial partial thickness burn. Again, so this is sort of the lesser degree of that second degree burn that I was talking about. So you see here how this is from a scald injury. So like dipping someone's foot into like hot boiling water or a bathtub that's too hot or something like that. You see how it has a very wet appearance to it. Again, this is a second degree burn. So it still has all of its nerve endings. It has most of its blood vessels. You see here how it has a very sort of wet, shiny, goopy look to it. You see how the skin, the first layer sort of the epidermis here is sort of just kind of peeled back. You see the skin on this toe is just kind of like peeled off. I had a gentleman in the ER one time who came in with a superficial partial thickness burn like this. He was a paraplegic, and his caregiver, again, I feel like I have so many stories of these negligent caregivers, but his caregiver would always Hoyer lift down him into the bathtub. Well, she didn't check the temperature of the water and just lowered him down into the bathtub. He had a burn that looked like this from basically the waist down, from sitting in this scalding bathtub. Now, not only is he immobile because he's a paraplegic, so he can't jump up out of the water like any of us would, but second, he's a paraplegic, so he didn't feel it, right? He can't feel this occurring. But lo and behold, it was pretty obvious after pretty quick that this water was way too hot, and he literally came into the ER with his entire second half of his body looking like this. I mean, just a scald injury from the waist down. Again, I'll never not think of that when I think of a superficial partial thickness burn. So that's a good sort of example of that. Here's a really good illustration of that issue I was talking about with when you have hypertrophic scarring and a sort of rebuilding of that skin in areas around joints. So you can see here around this gentleman's shoulder and or here in this sort of axillary area around his elbow, how the skin gets so tight and taut from that sort of non-functional scar tissue that grows back in the areas of that burn that it actually impacts the range of motion of those joints. So this is a good example of the scar contracture. So a contracture means when you can't move a joint in its full range of motion. To adequately have fixed this as this person was healing, they would have needed to have cut that tissue, that eschar tissue, to sort of allow for full range of motion. But you can see here how he can't fully extend his elbow, and he can't fully move his shoulder because of contractures from the tightness of that tissue that grew back in that area. This is, again, because of hypertrophic scarring, you have that decreased elasticity and that decrease in the stretch ability of the skin that grows back. And this is just kind of, so for your sort of reference, this was after a deep partial thickness and some third-degree burns on his torso and his arms is what caused these contractures around these joints. So again, a good example of that. This is a deep partial thickness burn. So this is, again, the second version or the worst version of a second-degree burn. You can see how here the skin just literally, the first layer, the epidermis, just literally can peel back down to some of those sort of dermal layers underneath. And then again, remember how I said those third-degree burns, those full-thickness burns can be sort of so disturbing? This is why. So this burn is a third-degree burn. So it's down through all layers of the skin into sort of the adipose tissue. But look how dry and sort of leathery it looks, right? It doesn't have that weepy, wet look that these other burns had. So even though it doesn't look as bad as those other ones we looked at, it's worse. And that's what's so disturbing when you see these. They just look dry and leathery. There's no blood supply. There's no nerve endings. It looks like a piece of leather. And that tells you, again, how bad those injuries can be. Complete loss, in this burn, complete loss of ability to hold on to moisture. There'd be circulatory problems, circulation problems, etc. So again, pretty disturbing when you see a burn looking like this. Okay. There's the rule of nines again. So let's talk a little bit about why we do this sort of configuration and this calculation of, okay, how much of this patient who's coming into the emergency room now or in the burn unit, in the ICU, whatever it may be, how much of this body has been burned? What is the percentage? And again, anything over 40% is really considered a major burn injury. And the reason that we care, not only because of the skin issue, right, the actual burn and risk for infection now because the skin is open, et cetera, but it's also associated with a lot of fluid and electrolyte issues as well. So associated with massive evaporative water losses, so just insensible loss of water vapor from the body because there's no barrier there anymore. Fluctuations of large amounts of fluid, electrolytes and plasma proteins into the body tissues can get really messed up and really out of whack. And one of the major sort of problems is that not only do you have this evaporative loss, but you have an increase. Now think about all the inflammation that's going on in the body with a burn. So what do we know about inflammation? We know that we get increased capillary permeability. So all the fluid is going to sort of seep out into the tissues. And you're going to have pretty widespread plasma protein shifts as well. So you're going to have a decrease of plasma protein in the capillaries themselves. And we know that when you have a decreased plasma protein in the capillaries, what does the fluid do? Out into the periphery, out into the interstitial space. So, okay, we just said evaporative loss, a major evaporative loss. Plasma protein shifts, so you've got like decreased albumin in the capillaries in the blood. You have increased capillary permeability. What do you think is going to happen to these people's blood pressure? In the basement, fast, right? These are extremely, extremely risky patients in terms of hypovolemia and hypotension. And so then, once you've lost all of this fluid, so there's no fluid in the vascular compartment anymore, it's all out into the tissues and weeping and causing all these problems out into the tissues. What about the amount of blood that is circulating? Is it getting back to the heart to be repumped out? No. So you see decreased cardiac output because there's no blood left in the system for the heart to pump out. So you see these major sort of, hemodynamic instability kind of situations with these patients. They're so severely hypovolemic, they're so severely hypotensive. You'll see generalized edema, all the fluid moves out into the tissue, and you'll see circulatory hypovolemia and hypotension, as I mentioned. Immediately what's going to happen after a big sort of widespread burn, like again 40% or more of the body, is something called the ebb phase. So immediate systemic consequences. You see, basically these people go into hypovolemic shock because all their fluid is outside of their vessels and into the tissue. So all the blood is shunted away from those major important organs like the liver, the kidney, the GI system, etc. So you see major sort of hypovolemic, hypotensive issues occurring pretty quickly right after the burn. Then within sort of 24 hours to a day later after the burn injury, you have what we call the flow phase. And this is kind of this hypermetabolic response that the body has to this burn to sort of then try to hyperdynamic circulation back to all of these organs and sort of basically sort of like a compensatory phase, so to speak. And this can really persist up for a long time because it actually takes a long time for burns and for burn patients to heal. So this type of like hypermetabolic, hyperdynamic circulation to try to sort of recalibrate and like I said, sort of compensate, can last for a long time for these burn patients. So we talked about major hemodynamic issues, major cardiovascular issues in these patients, which obviously can lead to major systemic complications. We're talking ICU, burn unit kind of patients. What do you think as a sort of initial response to these kinds of patients coming into the ER, coming up to you in the ICU? What's one of the first things we do to try to treat these patients and stabilize these patients, aside from the actual skin issues? Yeah. Pain is huge. Pain is huge. Exactly. So pain is a huge one. We're going to be hitting, especially if it's not a third-degree burn and they are feeling the effects of this, hitting these people up with major, major, major pain meds, narcotics, etc. What else? Antibiotics are a huge risk for infection. Good. And I heard fluid. Fluid. IV fluids on these patients until the cows come home, right? You cannot, and there's actually a equation that you actually do depending on how much of their body has been burned. And I think you'll talk about this if you haven't already in health and illness. You'll talk about this maybe next semester. The actual burn equation that you do to figure out how much IV fluid you slam these people with depending on how much of their skin has been burned. But I cannot reiterate enough to you how important it is for these people who are at profound risk for hypovolemia and hypotension and lack of blood flow to their organs to slam these people and resuscitate, basically, these people with IV fluid. So I wanted to be clear about that. Yeah? Yeah, not only because of the skin issue with these patients, but also how sick they are. These kind of people are getting, like, central lines. Yeah. You're not worried about little peripheral IVs. Yeah. Very good question. Okay. Here is a good picture, so to speak, of just kind of the pathways and the pathophysiological responses that we've already talked about here with burns, but it's just kind of a good illustration here for you. But again, it's a major insult to the body. So not only do you get all of these responses that we just talked about in terms of, hemodynamically speaking, but you think about the stress response that the body has. So increased catecholamines, increased cortisol, increased glucagon and insulin. You think about what those things that we already talked about throughout the semester do to your body and to sort of your hemodynamic stability. Then you've got all of that on top of the burn, on top of the loss of fluid. These people are sick. That's why they, when you think of like a burn unit in a major sort of big institution like KU or other similar kind of places, it's an ICU. And it's not just treating the burns and treating the skin. It's dealing with all of this hemodynamic instability that these patients have. I mean, they are sick ICU patients, not just because of their skin, but what's occurring, to their heart, to their cardiovascular system, etc. Yeah. That's the formula I was talking about. Yeah.
I was kind of thinking that they started, as I was getting out of the EMS, pull away from that fluid replacement regimen.
And just slamming them?
I'm not for sure what.
Yeah.
And I wondered what the new treatment was.
Yeah, right now they still do, like in the emergency room, they will still do that formula. Yeah, and it's you don't have to know it for the purposes of today in class, but it's like, you do the formula to see how much total fluid replacement the patient needs, and then like half of that, you give it to them in like the first 8 hours. Like literally, that's how aggressively you fill these people back up with fluid. But yeah, they still actually do that. And oftentimes, they were getting away from it for a while because they were worried that people were being a little too judicious in the amount of fluid being given, and so then they kind of went away from it for a while and just said, just slam them. Just bolus after bolus after bolus. But now they're kind of going back to that again. Yeah. Yeah, one more question.
With mercury burns, you said it's completely painless, but is there pain eventually that comes? So would you begin treating that even though they...
Yeah, there may be, and that was kind of the question before is, do those nerve endings come back? Will they start to feel pain and sort of discomfort in that area? It depends on how bad the burn was. Sometimes the nerve endings will never come back. There's been enough nerve damage to that area that they won't have full sensation to that area. But if it does, yes, then you're very judiciously, pain medications, etc. Yeah, good question. Okay. All right, and this is just kind of a reiteration of all of those things that we talked about. But again, to drive home, burn recovery is not just about the skin. It's very complex, it's very prolonged, and unfortunately, complications that you see, not only from infection, but cardiovascularly speaking, is truly the rule. You almost sort of expect some pretty severe complications from these intensely burned patients. It's pretty rare for you not to have pretty profound complications. And again, that's why these patients are in an ICU like a burn unit. Okay. And there's that hypertrophic scarring that I talked about. All right. And here's another good picture of that autograft, of the skin graft that we talked about. All right. Quickly switching gears here, I want to just bring your attention to a couple of the objectives here for the pediatric population. Poor kids. I always run out of time for them. Poor children. I actually knew that I always do, so I'll do a voiceover PowerPoint for you for most of the pediatric stuff. But if you look at the slides, a lot of it is kind of repeat from what we've already talked about. So if you look at the slides for the pediatric population, there's many slides on atopic dermatitis. So again, we've talked about that already in the adult population. Take a look at that with the pediatric population, and I actually do have a good picture here for you on that. The way atopic dermatitis looks in these children. Again, that lichenification, that toughening and thickening of skin around some of these lesions. This is a great picture of that lichenification that occurs around some of those lesions in this kid. Again, what is atopic dermatitis very closely linked to in children? Asthma. Good. Some sort of allergic sort of predisposition. Good. Very good. So take a look at the atopic dermatitis information. And then the last thing I'll just kind of briefly talk about here before we leave is a bacterial infection, and that's impetigo. This is usually a superficial skin infection that results from either staph or strep. You see it more commonly in hot, humid climates, and the clinical manifestation of impetigo is these very sort of erosive ulcer-looking things that kind of have this brown, yellowy, honey kind of color to them. They usually arise as a primary infection. Bacterial invasion occurs usually through minor breaks in the skin, and the treatment of choice is usually just some sort of topical treatment for impetigo. But again, usually the crusted skin erodes and oozes, and it's actually the reason I put this with the children content is it's actually one of the most common bacterial infections in infants and children. So you see it a lot in like daycare centers and things like that. The mode of transmission is either direct or indirect, so that's why you see it a lot in like child care centers, because touching each other's toys and clothes and blankets and diapers and things like that. It actually can spread pretty quickly around places like that. Also, it can spread really quickly around other kind of places where you have like sort of a lot of crowding and unsanitary conditions. But again, also clean places like daycares that just so happen to have close contact with a lot of babies. And again, topical creams are usually what you will use most commonly for treatment of impetigo. Here's a really good picture of impetigo. This is very classic that you would see. Again, that sort of oozy, crusty sort of appearance that's kind of yellowy, browny, honey colored. This is a really good illustration of impetigo. Okay. I think we're going to stop there so you guys get a little bit of a break here before your next class starts. And again, I will do a voiceover PowerPoint for the next content. It won't be that long, but I just want to make sure you get the content and I kind of go over it with you prior to the exam. Keep it